So the reception and triage routine in the emergency department is a bit of a source of anxiety for some folks. So I'm creating this video as a training resource for you, both pre and post live. This is going to be the full explanation with details. So it's probably going to be a fairly lengthy video. However, I am going to have quick demo videos for you to observe just rapidly what is done in that routine. If you don't need an explanation, you just need to see it for your purposes. So I already have my ECTAS app logged in and open, and I've already got my ED tracker logged in and open as well. So those are two things that you're going to want to make sure that you have up and running, and you're going to want to leave those logged in for when you're working in the units so that you don't have to log in and log out every time. So a bit of a disclaimer here. So whenever a patient arrives into either the triage department or into the ambulance bay, we do want to do our ARI screens immediately at that point, and ask the patients the appropriate questions regarding whether they've had exposure to COVID and if they have the symptoms that we're screening them for. And you will don your appropriate PPE prior to contact with the patient. So a bit of a disclaimer there. You do want to make sure that you do those things, even though you're going to document them later in the routine. You do want to make sure you do that in the reception portion of your routine. So the patient arrives into the department and has their health card in hand, which is the preferred method to search for the patient. So I'm going to go ahead and click on this reception button. Now the cursor automatically flows to this search box, which is pretty convenient because that's where you need to be. So now we're going to enter the patient's health card information into this box. Okay, now the health card number is by far the preferred way to do a search for a patient. However, you can use their name or date of birth if you need to and they don't have a health card. You must do a search in this box before clicking on this new patient piece. If you cannot find the patient by doing this search, then and only then will you go to the new patient tab. Otherwise, you're creating a new account for an existing patient, and it creates a bit of a problem for the system. So you do want to search the system. The other thing that I want to point out here, so you've got statuses here. You got a walk-in, EMS, and call-in status. So you want to make sure that you keep the default of walk-in here. Even if the patient has come by EMS, we do not want to select EMS here. We want to keep the default of walk-in. We will deal with the EMS portion of that visit later in the routine if that's what we need to do, but we do want to select walk-in at all times. So now that I've got my health card information in the box, I'm going to go ahead and press enter, and you're going to notice that there's a little pop-up that shows up. This pop-up is asking me, do you want to search the system for an existing patient that meets those details? The answer to that is always going to be yes, I do. So I'm going to go ahead and click the search button here and look for a patient. Because the search is specific to this health card number, it'll automatically pop up only one option, and that's the patient that's associated to that number. If I had used the patient's name or date of birth, I may have multiple options here that I'd have to choose from, and then I would have to make sure that I'm vetting that patient for accuracy of name, date of birth, and where they're actually from. They're usually going to be ordered from best matches to lowest matches by color code for you as well. But it's always preferred to use the health card number, and then that's not a problem. If you have not generated a patient here, then and only then you can go to this new patient button and you'll complete the routine that way. So we're going to go ahead and just click on the patient box. So now this box here is indicating to me that the patient has a registration account somewhere in the building. This may or may not happen in real time. but we can go ahead and ignore this box. It's not going to have any effect on anything that we're going to do. So this is the reception routine for Meditech Expanse. So you're going to notice that there's already information here about the patient. That's because it flowed through from the existing account that we selected. If this were a new patient, we would have to enter all this information manually, which is basically the only difference between the two options. So I'm going to verify. You're going to notice that there's asterisks in front of some of the options. Those are mandatory fields and must be completed prior to moving forward. So we're going to verify our patient's date of birth, and she's sitting in front of me, and I have her health card, so I can do that. And then I'm going to go ahead and put in her stated complaint, which is a laceration to the left great toe. And the chief complaint pertains to the CEDIS complaints. So if you're not sure which CEDIS complaint pertains to this particular visit, you can go ahead and click on this arrow, and you're going to have a list of CEDIS complaints that you can choose from at that point. So you can go ahead and do that, or you can just put in the word that you think is most associated to your complaint, and more than likely it will automatically pop up an appropriate CEDIS complaint for you, in this case laceration puncture. The next mandatory field in here that we need to deal with is this triage level. Now this should not be confused with the patient's actual acuity triage when they arrive. The number we're going to put in here will always be a 5, and it is strictly a default placeholder for the system to know where to put the patient's triage score from the ECTAS app. So this number does not indicate the patient's actual acuity. It is strictly a placeholder. So we're going to go ahead and select that. So now for our EMS patients, if your patient is arriving by EMS and not in the triage room, this arrived by here, you can click on this box and open up that option, and you can change the patient status at this point to ground ambulance. By changing the patient ground status to ambulance, you will let the system know that the patient came by EMS. So in the original piece, you still are only going to select the walk-in piece. And you are going to define whether or not the patient came by EMS in this reception routine right here. So now that we have all these mandatory fields filled out, the next step is critically important. If you do not save this before you go to ECTAS, the information that you put in to ECTAS will not flow over to Expanse. It is critical that you press the save button and finish that piece before you go to ECTAS. You will also notice that you now have an option to print an armband. We will have an armband printer in Triage, and we will be applying that armband to the patient. So you're going to select your printer, and then you're going to go ahead and print it and apply that armband to your patient, meanwhile verifying their name and date of birth as well. So the next that you'll notice there's a pop-up here. So because we put in a CEDIS complaint of laceration puncture, that complaint has a number of order sets and directives associated to it, which is popping up and saying, hey, you've got this option. At this point in the routine, we will not be applying directives or orders. We're going to do that later once we've actually done our vitals and assessed the patient. So we're going to click no thanks, but we're going to make a mental note that this is actually available to us, and we will probably want to apply those at a later point in this particular routine. So for now, we're going to click no. So now our patient is received into the system. I am not seeing anything on the screen, and the reason for that is because I am defaulting into my list. Now, if all of the patients that we do in the reception routine will automatically flow to the waiting room tracker. So you're going to click on this waiting room tab, and this is where you're going to see your patient. Miss Cut a Toe Off is right here at the bottom of the list, and she is indicated in the waiting room. Her registration status is pre-ER. So what that means is registration needs to register her still. For nursing, there is nothing for us to do for that piece. The information we put in the reception routine will automatically flow over to the registration department, and they will complete the registration whenever that happens, and whenever it's convenient for them. It will have zero impact on any of the routines that we do in nursing. We can still administer medication, put in orders, document on the patient. It will have no impact. The only two things that it will affect is you will not be able to discharge your patient, and you will not be able to admit the patient to a bed until they have been registered by the registration department. So that's the only piece. You'll notice here that you do have a CTAS number, but that CTAS number is strictly a placeholder at this point because we have not done a triage and EC test yet. And once we do that, it'll flow over. So which we're going to do right now. So we're going to go over to our pre-triaged patients here. And if you're not seeing your patients, it's probably because you're in the wrong tab. So you need to make sure that you're in the pre-triage tab of your ECTAS app. And we can see here that Miss Cut a Toe Off is in the system. And you can either access her triage routine by clicking on this button here, or you can click on it, or you can click on this button as well here. And that'll bring you into the same routine regardless of which one you choose. So in this particular application, you do want to repeat your your stated complaint. So you'll notice here, because I've done previous entries of this very same complaint, it'll show up as an option for me to click on. Do take advantage of those, and as you do more triages, you will have more options on your list, and it'll probably become more efficient and facilitate that process. And then the next thing I'm going to do, I'm going to put in the laceration of the CETUS complaint for us. And you do need those two details because the printout that we're going to be utilizing in the emergency department for the physicians does have to have those details on it. So because I changed my patient's status to ground ambulance in our reception routine to show you, I now have access to the EMS portion of the tabs. And here is where I would describe what the EMS has told me was the reason for them presenting to the call. When it is a walk-in patient in the triage department, I am not going to do that. I'm going to go straight into the subjective tab to put in my own accounting of the patient's complaint. Now you'll notice that a pop-up came up because laceration and puncture is associated to this recommended assessment of tetanus status. You do want to take advantage of that and put in whether or not their tetanus is up to date. In this case, we'll say that her tetanus is up to date, and we're going to add that to our subjective notes. Then we're going to go ahead and put in our presenting complaint. So presents to ED with laceration to left great toe, dropped heavy object on foot, resulting in pain and laceration, bleeding active at the time of incident. Now you may also want to comment on pain here. If your pain complaint is not congruent with what the patient's behavior is, then you could address it here. However, pain does get addressed in the vital signs portion of the triage, so it can or can be left out at this point. So we can say, like, patient agitated in pain, which would be appropriate for dropping a heavy object on your foot. You'll also notice that you have the option to spell check things. So that is my subjective detail. Then I'm going to click on the objective tab. So under here, I'm going to put approximately 2 centimeter laceration to posterior of left great toe, active bleeding in ED. And that's probably adequate there. So under the treatment tab now, because I've entered things previously, I have options here that pre-populate, and I'm going to go ahead and wound cleanse and dressing apply because that is what I would do with that particular patient. So I will do that. I may also use a medical directive. So I might put a medical directive initiated for pain, which I'm going to do after this routine here. So those are two things that I could put in there. And those are the only pieces that we need out of this section of ECTAS, as these three other sections will get dealt with in Meditech directly. So you don't need to put any other information here. So you're going to do your EMS, subjective, objective, and treatment only, the first 4 tabs. Now we're going to go ahead and put in our vital signs. So again, you'll notice that any previously entered information pre-populates. If something fits, go ahead and take full advantage of that. I do like people to add the details to where they got the information from. So go ahead and put those in. And the more information that you put in, the better. I'm going to go ahead and put in the respiratory rate. So for blood pressure, if you're doing a cardiac assessment, you may want to do a bilateral blood pressures, in which case then you'll indicate that you're doing one on the right, and then you'll add a second blood pressure and indicate it on the left. We're not going to do that for this particular patient, but you do want to know that you do have that option. And then so our saturations, so again, because I have existing data there, I can go ahead and take advantage of that. And we're going to do our pain scale. So she is telling me that her pain is an 8 on 10, and it is central and or peripheral and acute. So now if you're not sure what qualifies as peripheral and acute, you do have the option. If you hover over this eye icon that is there, it will give you all of the details as to what qualifies as central pain or what qualifies as peripheral pain or acute pain or chronic pain. So you do have the option here to clarify for yourself which one of those options you should choose based on the information presented on that icon. So that's always a bonus, and you can put, if your patient's unable, you could put that as well on that. So for GCS, now not every patient is going to need a GCS, as for example a sore throat or something minor might not need that. However, any patients who you feel may potentially deteriorate or have the potential to deteriorate in the presentation that they have, and obviously for traumas and head injuries, this is non-negotiable. You are going to want to put a GCS score for those patients who are sicker and have the potential to have deterioration at some point. You can go ahead and put a 15 or the score number if you know it directly off the top of your head, or you can select from those lists as well. Cap refill again. So this is one that if you select this, it may bump one of the modifiers to increase your patient's CTAS score. So it's important if you've got a sick patient to address that piece. Blood glucose. So we have printed a armband for our patient. So we actually have the ability to go and grab a glucometer. We're going to scan that patient's band and do a blood sugar on the patient, and that will flow automatically to the patient's chart. And then we can put the information in here for our physician or our other care providers to be aware of. So you can do a glucose, and you will be scanning the bracelet in the triage department. Weight is dealt with in expense, so you don't need to deal with it here. High mechanism of injury. So this one is very important. If your patient presents to the department with something that qualifies as a high mechanism of injury, it will automatically bump your CTAS score to 2. If you're not sure what qualifies, again, your eye will give you the information that is required. So all of these options in this particular window will automatically bump your patient's CTAS score to a 2. So you don't want to ignore that. Same thing with immunocompromised and blood disorders. Those will also bump your patient up in CTAS score. So you don't want to ignore those if they are applicable to your patient. The very last step of doing triage is to look at your modifiers. So the modifiers are broken into color segments for score. So yellow is 3, red is 2, and blue is 1 here. So you're going to look at the modifiers above to make sure that you're not overlooking any of the details that may increase your patient's triage score. The frailty modifier is one that oftentimes gets overlooked as well. So do make sure that you address this frailty modifier, especially for your patients who are only triaged at a 4 or 5. They probably should be 3s at minimum, and the frailty modifier will automatically bump them to a 3 if they meet the criteria in this window right now. So keeping in mind, this is also adult and pediatric patients. So anybody who has a caregiver at home and requires extra care, mobility problems, that sort of stuff, will probably fit this frailty modifier. So don't overlook that when you're triaging a patient. Another last detail that I want to point out to you when you're doing your triages is if the patient has had previous visits relating to this complaint, you will have access to the information of that previous visit here in this box. So sometimes it is good for the care providers in the emergency department to know that the patient has been here before and what the details of that visit were. You can go ahead and add that information, and it'll pop automatically onto your subjective data here. So you can go ahead and add previous visits information if it pertains to the current visit and you think that it will be helpful as an addition to the information. Once we have completed our triage routine and EC test, we can go ahead and click this I am done tab, and you will automatically flow over to the triaged patients tab of that app. Now, before you leave this app, you do need to print off a copy of this report. So it'll automatically show you this. So this copy will go on the clipboard and replace what we currently use as a yellow sheet for the patient. This is not part of the chart. It will get discarded once the patient leaves. So orders cannot be written on here, and this is not official documentation. Anything that is written on this piece of paper is strictly note-taking for the physician. It is not going to be actual orders. If the physician wants an order, they must put it into the system at minimum, or at least communicate it to the nurse directly. It cannot be on this piece of paper. It is strictly for a placeholder note-taking purpose only. And then we're going to go ahead and print that piece of paper, and then we can go ahead and close that off. And now we can go back to our Expanse app. So now that we're back in Expanse, the information that we have put in Triage should have flowed over and changed this triage score and put the patient in the appropriate order of care. And you'll notice here that the status of the patient is now triaged. So the patient is actually triaged, and somehow in the time that we were doing what we were doing, the registration department has gone ahead and registered our patient. So she is registered into the system. Our triage notes are here in the system as well. So now the patient is still in the triage department with us at this point. And there's one last piece that we want to do before we can dismiss them from our triage department or park them into a bed if it's an EMS patient. We're going to want to go to this triage tab here, and we're going to click on that. So this is where we're going to deal with our infection control screens and our extra data. This ISAR, so any patient over the age of 65 or older will automatically trigger an ISAR, and this is the same ISAR that we are doing in current state in triage, and it is important that we complete that so that our GEM nurse will be able to address any issues there with the patient that may pertain to their needs out in the community. And yeah, so once we've selected all of those things, we can go ahead and click on the pencil, and we can go ahead and fill out that information. So in this particular case, the patient is okay to answer those questions. They have not been outside of Canada. They are not sick. They don't have any cold symptoms or diarrhea or nausea, vomiting, any of those things that we're worried about, or rash, all those things. They've not been exposed to somebody who's got COVID or recently had COVID or has been out of the country or any of those things. So we're going to go ahead and input our routine practices here. So this lady is a pretty robust 80-year-old and does not have problems with mobility or falling. She just happened to drop a heavy brick on her foot. So we're going to go ahead and click no for any of the risks that we have here. And she is a very kind and sweet little old girl. So we're not worried about her being violent. So we're going to go ahead and click no for the violence behavior pieces. You do want to put in a height and weight for the patient. So a patient tells me that she is 5'6", and we're going to go ahead and select those, and that's going to be her stated. And she's telling me that she is also 140 pounds. So we're going to go ahead and select that, and those are stated. You do need to put whether it's stated or actually measured. And then so your ISAR piece. So before the patient came, did they have any problems? This lady says no. In the last 24 hours, did she have any needs? Or just prior to her illness, she's a no, she's still okay. She's not been admitted to the hospital recently in the last 6 months. So problems with vision. She does have problems with her vision, but they are dealt with glasses or surgery. So cataracts and somebody wearing glasses does not qualify as vision problems. When we're referring to vision problems in the ISAR, we're referring to somebody who has uncorrectable vision problems that impairs their functioning at home. So it's not clearly stated in this, but that is what we're referring to with vision. So if somebody is due for cataract surgery or has glasses, that should not trigger a yes under this question. And then, so any generally serious problems, no. She's not on more than 5 medications, so we're good. So her ISR score is going to be 0. And that deals with that portion. So here now, you're going to pop up asking if you want to update the height and weight on the patient's chart, and you do want to do that. So we're going to go ahead and have that. So now those things are documented. The next pieces that you want to deal with in this particular window. So allergies, we want to click on the allergies, and we do want to confirm whether the patient has these allergies, and we can go ahead and add and remove allergies if they're inaccurate or if there's more allergies that they've since discovered. So we'll deal with that piece there. And then the next thing we want to do, so special indicators, she does have a visual impairment as a special indicator because she has cataracts. However, as I mentioned in the ISAR piece, that's not going to be triggering an ISAR score, but it is something that we need to indicate in her special indicators. Home medications. So this is where we get our patient list. Hopefully the patient's been here before and we already have a list of medications. If not, we're going to enter these manually. So in our case, our patient's been here before. You must make sure that you verify what the patient is on at this point in your assessment. So Mrs. Cut a toe off, are you still taking the aspirin? Yeah, I take that. I take it every day. Did you take it this morning? Yes, I took it. Did you also take your levodopa? Did you take that last night? Yes, I still take it at night and I took it. And then you're going to do the same thing for all of the medications. Now, maybe on the perindopril, Mrs. Kadatoff says, you know what? I was taking 2 milligrams, but my doctor bumped it up to 4 milligrams. So I'm going to go ahead and change that for her. Sorry, I accidentally clicked on that piece there. So she did take it today, and now we've corrected the dose on that perindopril. So it's going to be accurate. And you want to make sure that you check with the patient on the doses, that you have updated those pieces of information. Preferably, you want to list from the pharmacy for the patient. If one's not available, that's okay. And you're going to have a minimum of 2 sources, the same way we do with our current med reconciliation practices. And now the medication list will be updated on our patient, and you can go ahead and put a pharmacy here as well if there's none for the patient in existing state. And now that we've completed this piece of the triage screening, we can go back to our home screen. At this point, your triage is complete and the patient is going to be waiting to be brought into the department for further assessment. However, if you do have a medical directive or an order set for the presenting complaint, this is a good time to also deal with that piece while your patient is in triage. You may want to give them something for pain or deal with a fever, or you may initiate x-rays for the injury that the patient has. So we can go ahead and click on our orders portion, and then our physician doctor should be the first one to pop up, and it is going to be a medical directive that we select. And then so you'll notice here that the system will automatically suggest medical directives based on your patient complaint. So in this particular case, our skin laceration does have a medical directive. We have done our med reconciliation piece, and then we are going to want to give this patient something for pain, right? Actually, you know what? I prefer ibuprofen, so I'm going to go ahead and give her ibuprofen instead. And then you also have the option to put this lidocaine let gel onto the laceration that you have, so that when they finally do need sutures, they will be able to receive that. And if the patient's tetanus status is not up to date, you can go ahead and give them tetanus at this point as well. So there's a lot of little things that you can do ahead of time prior to bringing the patient in. Or you can at least initiate that tetanus shot so that it can be given in the department at a later time. So you do want to deal with that in that particular directive. And then you can go ahead and submit. And then we can go ahead now and administer the things that we have put in so that our patient has received something for comfort. So again, I would scan my patient's bracelet at this point, but I do not have a bracelet in front of me for this particular incident. So I'm going to go ahead and override that manually. And yes, we are going to administer that dose of the topical agent. And I am going to give her something for pain for her 8 out of 10 pain. And we're going to go ahead and give her that as well. And then we are going to go ahead and click OK, and that will be given to the patient so that they have a more comfortable weight at this point. Bit of a glitch there. So now that I've dealt with the patient's pain, they're comfortably waiting in the waiting room, and if we needed x-rays, we would have put in x-rays as well. And now it's time to bring the patient into the department. So the routine for bringing the patient into the department is so you want to first find your patient, select your patient. You're going to want to sign up for your patient. Being the person who brings the patient in, you want to sign up and put yourself on that patient's identifiers, because if the physician or anybody else has questions about the patient, you are going to be the most appropriate to answer those questions. However, if for some reason you are not able to take accountability of this patient, you can undo your sign up at any given point and absolve yourself from being connected to the patient. This sign up routine is not it does not absolve everyone else in the department from accountability of the patients. We are all equally accountable to the patients in the department, and if a patient needs something, you can deal with that despite not being the person indicated on this field. And if you're assuming care of the patient as a more primary state, it might be a good idea to sign up for the patient and overtake that patient for yourself as well. And if you're looking at the tracker and you're finding that there's one individual who has their name on pretty much all the patients, that may be an indication that we need to do a few, we need to take up a little bit more of the workload for that person. We do want it to be a fair and equitable department to work in, and if the workload on the screen is showing that maybe we're not doing as much as we should, this is a good time to address that. Okay, so I'm signed up for the patient. The next thing I want to do is I want to bring the patient into the department. So I'm going to bring them in and I'm going to assign the room that they're going to be in here. So you might notice some of the rooms might be dirty. As long as I know that housekeeping has dealt with the room and it's clean, it doesn't really matter. You will be able to put the patient in that room. One situation that may arise, so if you've got a patient where you've got two people going into the same room, the system will not allow you to put both patients in one room. So if that is what you're going to be facing, you're going to want to choose treatment flex for that patient's presentation, and you're going to want to put them in one of the treatment flex rooms so that they show up. And then in your yellow tab and your yellow sticky note on the status bar, you can then indicate what room they are with what patient, and then that will make it helpful for other staff because you won't be able to put two patients in one room. So for our patient in this particular case, we're going to put her in exam room 1 because it is open, and we're going to go ahead and save that. And now, so you'll also notice that my patient is no longer on the waiting room tracker. Okay, so the patient, because I signed up for them, they automatically show up on my list. But if I want to view the whole department, there's two tabs that I can do. I can do the all patients tab, but I can also, the preference that I would pick is the exams treatment flex tab here would have all of the patients in the department, including the treatment flex rooms. So when we use those rooms, they would show up here as well. So it's a matter of preference at this point. So I'm just going to work from my list for the purpose of this video. So I brought my patient in and I'm ready to do my initial assessment. So what I'm going to do here is I'm going to change the status of that patient to, what can I put here? Sorry, I wanted to have nurse assessing. That's what I want. So my process is gonna be nurse assessing. That way people, when they look at the status board, they'll know that I'm in with that patient. Okay, so then I'm gonna go to my work list here and I'm gonna want to document on this patient. So there's a couple things here. So the chief complaint or CETUS complaint put into the patient will automatically generate a primary assessment source. So wound laceration assessment is going to be my primary assessment. Now, for a patient like this, that's probably going to be all that I need to document on. However, if a patient is a little bit sicker, like our CTAS 3s and our CTAS 2s, there may be more complex assessments required than what's in that initial assessment. That's where you will follow it up with your secondary assessment, and it'll add all the other systems to assess. Same thing, so if you want to reassess your patient in triage, before you bring them in, you can actually do a triage reassessment here, or you'll be able to do it from the triage tab as well. It is the same assessment regardless of where you do it. And so if I may or may not need to do another set of vitals on the patient coming in, so I can deal with those things as well. And then pain assessment. So if pain as an acute problem is there, you will have pain in the vital signs, but sometimes I like to do the pain piece, especially if it's my initial assessment, in the actual pain acute assessment. And then if you're starting an IV and whatever, you're going to document on those things as well. So we're going to go ahead and click on our documentation tab. And here, so this is my initial assessment. I have reviewed the triage information. The patient has not changed. This particular wound, so this is the first part is going to be that wound assessment. So it's an accidental wound, and her tetanus is up to date. We've already ascertained that. And here I'm going to select the source of the wound. So it's her left great toe. And then I'm going to go ahead and put that in there. Okay, and then she has a laceration there. And it is not approximated. And there's no wound staging pieces for that particular wound. I'm going to want to indicate here that the wound is 2 centimeters long, and there's sanguineous exudate. We'll say a small amount. And then we can put, what else can we put? And maybe there's some bone visible, maybe there isn't. Surrounding tissue may have edema, may not have edema with a fresh wound like this. Obviously, it's not going to be granular or a slough tissue if it's a fresh wound. And then, so we have a dressing. So the dressing applied initial dressing, or we can put reinforced if she was bleeding through or whatever, or we may do a cleanse. We may do a wound cleanse here in the emergency department with some saline, and then apply a gauze dressing. So we can actually put. I can find what I'm looking for. So irrigation with normal saline, and we can apply some gauze to that dressing, and voila, we're pretty good there, and that should be that piece. And now if this secondary assessment, so if the patient had more significant injuries, then I could go through by system and then document on those systems. For this particular patient, I'm not going to do a secondary assessment. I could also come through and complete my pain assessment as well, and my vital signs. So here I have my vital signs, so I may do a repeat set of vitals on this patient. And then, so I'm going to put here, electronic monitor, and so pulse is 88, it is regular, this is a tympanic temperature, and the respirations are still 16, on room air, and she's still statting at 98. And then we can put a blood pressure, and we're just going to use the arm, and she is sitting, and we're going to go ahead and put 125 over 80. Automatic cuff, and it is at rest. Now for my pain assessment, like I said, I like to skip the one in the vitals and go straight to the acute pain assessment when it's an initial assessment. So I'm going to put significant findings here because she is telling me that she's still having some pretty significant pain. So it is the left toe, or it is toe, and first digit. The order of things is a bit different from one place to the next. And her pain scale is now 7 on 10 because we did give her something for pain, and it's aching, and it probably is radiating a little bit to the foot. And she would have pain at rest and with movement, and she probably has some facial grimacing with that sore foot, and it probably makes it worse with activity, I would imagine, and it's probably constant pain. And then we gave her some pain medication in the emergency department, so we can indicate that as well. And that would be the completion of documentation for having brought the patient into the department. And then once we have done that, the only thing that's left to do is, sorry, I'm just going to get out of here. I didn't do anything on the secondary assessment, but sorry. Okay, and now that I've completed my piece of things, the patient's in the department, they've been looked after, I've done an assessment, I've documented my assessment, the physician is now the next person to see the patient. So I'm going to now go to the status, and I'm going to put the patient to be seen. And that is now going to show up on the physician's to be seen tracker as a patient that they need to go in and see. And they will have that paper copy of the triage in front of them to also prompt them to see the patient. And that is the full assessment, triage, and bringing in the patient. And this video is over 40 minutes long. But I will tell you right now that the quick videos are about 3 or 4 minutes long. So it really doesn't take this much time to do it. But I like to explain things thoroughly. So this is going to be your resource for that explanation.